Okay, thank you, everyone. This session is now reconvened. We do have a short order of business that we have to get to before we get to the next session, which is we need to put a motion on the table for the combined immunization schedule work group. So if we are able to put the motion up on the slide, it looks like this is the vote to approve the recommended child and adolescent immunization schedule and the recommended adult immunization schedule. We're doing both in a single vote. Okay, just confirming. Do I have anyone who's willing to make a motion? Dr. Alt.
I move that we accept the language on this slide.
Thank you. And a second? Ms. Bata.
I second that motion.
Thank you, Ms. Bata. Okay, so it's been moved and seconded that we accept the recommendation language on the slide. Are there any questions, concerns people would like to raise? Okay, I see no hands raised, so what we will plan to do is move this motion to vote after the public comment session. Next, we'll move on to the orthopoxvirus vaccine session. We have Dr. Pablo Sanchez, who is the chair of the orthopoxvirus vaccine work group, who will provide an introduction and overview of today's session. Dr. Sanchez.
Good afternoon. Next slide, please. Thank you, Grace.
We're trying to move to next slide.
Next slide.
Yeah, we're working on it. Sorry.
Okay.
There we go. Okay.
No, so I just want to thank the other members of the work groups, certainly the previous chair, Dr. Bell, and then Dr. Chen as well. But I also want to just take a moment to thank some of the ex officio members, especially Dr. Montgomery, who provided valuable input, and liaison, Dr. Minkoff, who provided very important information and recommendations with respect to pregnancy, and then as well as the invited consultants, Dr. Razek and also Dr. Isaacs. Next slide. And of course, the CDC contributors, and you'll be hearing Dr. Rao and also Dr. Peterson. They've invaluable. Next slide. So on the ACIP meeting from September 29th, we provided background information important to understanding evidence to recommendation framework. We developed the 5 policy questions for the JYNNEOS vaccine that we will be discussing today. Work group discussions in September meeting have focused on clinical guidance for the use of the JYNNEOS vaccine, including importantly the contraindications and precautions and warnings, and then the wording of the proposed recommendations for today. Next slide. So today, Dr. Peterson will be discussing the clinical guidance for the use of the JYNNEOS vaccine, and then Dr. Rao will present summary of the work group considerations and proposed policy options. And then we'll have the orthopoxvirus vaccine vote. Next slide. So the anticipated guidelines you can see here today, we'll have the clinical guidance and vote, and then followed by hopefully a MMWR publication recommendations in early to mid 2022. Next slide. Thank you.
Thank you, Dr. Sanchez.
Hand it over to Dr. Peterson.
Great.
Thank
So,
you.
Dr. Peterson, the floor is yours.
Great. Thank you very much for that introduction, Dr. Sanchez. And as you mentioned, I will be discussing the proposed clinical guidance for the use of JYNNEOS. In terms of a brief outline, after some background information, I will discuss the contraindications and precautions and warnings, as well as some proposed guidance for minimizing the risk of occupational exposures, as well as some guidance surrounding titer testing and starting work in laboratories. As a brief reminder, the vaccines that are under discussion today are ACAM 2000 and JYNNEOS. The major difference between these vaccines is that ACAM 2000 is a replication-competent vaccinia-virus vaccine, while JYNNEOS is replication-deficient, and consequently with ACAM 2000, you do see a vaccine site lesion or a take, which you do not see with JYNNEOS. And consequently, there is a risk of inadvertent inoculation and autoinoculation with ACAM 2000, which does not exist for JYNNEOS. And there are other serious adverse events which occur with ACAM 2000, which are expected to appear with fewer frequency with JYNNEOS. Both of these vaccines are licensed by FDA, and their effectiveness was evaluated by comparing the immunological responses of these vaccines with their predecessor previously licensed vaccines. As another quick reminder, the proposed recommendations for these vaccines are for persons at occupational risk of exposure to orthopoxviruses, that being research laboratory personnel, diagnostic laboratorians, as well as response team members. It would also be offered under shared clinical decision-making to persons who administer ACAM 2000 or care for patients with infections or after vaccination with replication-competent virus vaccines. The vaccines would also be recommended as a booster for persons who are at continued or sustained risk for exposures to orthopoxviruses, and the frequency of the boosters are shown here in the table. As some additional background, there are severe vaccinia virus complications which can occur following vaccination with replication-competent vaccinia virus vaccines or after occupational exposures and infections with orthopoxviruses. Shown here on this slide are progressive vaccinia and eczema vaccinatum, which can occur in individuals with immunocompromise or atopic dermatitis, respectively. And these complications are due to uncontrolled viral replication. There can also be severe vaccinia virus complications related to inadvertent transmission. For example, fetal vaccinia can occur following vertical transmission to the fetus. And as we've discussed, autoinoculation and inadvertent inoculation can occur as well. And these can be serious when they affect anatomic areas of particular sensitivity like the eyes. Lastly, there are severe vaccinia virus complications of uncertain etiology, for example, post-vaccinal encephalitis and myopericarditis. And I'll note here that no confirmed cases of any of these severe vaccinia virus complications have been reported in any of the clinical trials with JYNNEOS to date. Although with respect to these severe vaccinia virus complications of uncertain etiology, there does still remain a theoretical risk that they could occur, given that there's hypothesis that they may be immune-mediated phenomenon rather than direct viral infection, which is dependent on the replication status of the vaccine. So in this table, I'm showing the proposed ACIP contraindications for both ACAM 2000 and JYNNEOS. The contraindications for ACAM 2000 are shown in blue, and these are unchanged from previous ACIP recommendations. There was no significant new safety data to suggest a need for a change to the current contraindications for ACAM 2000. And the changes in this table are highlighted in red. And as you can see, for JYNNEOS, the working group is recommending a contraindication for persons who have a serious vaccine component allergy. And this recommendation is made in recognition of the currently available safety data, as well as the population is the subject of these recommendations. Now, we've provided some additional information as well as some precautions and warnings in the footnotes, and I will review these in the following slides. Firstly, we've noted that JYNNEOS is a replication deficient vaccine and therefore should not present a risk of transmission to household contacts. With respect to persons with atopic dermatitis, eczema, or other active exfoliative skin conditions shown in the first bullet, these individuals are contraindicated for receipt of ACAM 2000. However, studies evaluating JYNNEOS in persons with atopic dermatitis have demonstrated immunogenicity in eliciting a neutralizing antibody response and did not reveal any significant safety concerns. With regards to individuals with immunosuppression, as outlined in the first bullet, these individuals are contraindicated for receipt of ACAM 2000. And the working group has noted that immunocompromised persons, including those receiving immunosuppressive therapy, may have a diminished immune response to JYNNEOS because of their immunocompromised status. Pregnant women are contraindicated to receive ACAM 2000. However, available human data on JYNNEOS administered to pregnant women are insufficient to inform vaccine-associated risks in pregnancy. Working group did note, however, that animal models, including rats and rabbits, have shown no evidence of harm to a developing fetus. Infants aged less than 1 year are contraindicated for ACAM 2000. And we've made a note that JYNNEOS is not licensed for persons less than 18 years and has not been rigorously evaluated in this population. And for that reason, caution should be used when considering the administration of ACAM 2000 or JYNNEOS to children and adolescents aged less than 18 years. With respect to breastfeeding women who are contraindicated for receipt of ACAM 2000, the safety and efficacy of JYNNEOS has not been evaluated in breastfeeding women, and therefore it is not known whether JYNNEOS is excreted in human milk, and data are not available to assess the impact of JYNNEOS on milk production or the safety of JYNNEOS in breastfed infants. However, since JYNNEOS vaccine is a replication-deficient vaccine, there should not present a risk of transmission to breastfeeding infants, but nonetheless, caution should be used when considering the administration of JYNNEOS to breastfeeding women. With regards to individuals who have an underlying cardiac disease or 3 or more known major cardiac risk factors, these individuals are contraindicated for primary vaccination with ACAM 2000. However, clinical studies have not detected an increased risk of myopericarditis in recipients of JYNNEOS. Persons with underlying heart disease or more than 3 major cardiac risk factors should be counseled on the theoretical risk of myopericarditis, given the uncertain etiology of myopericarditis associated with replication-competent smallpox vaccines. So lastly, the working group did want to include guidance for minimizing the risk of occupational exposures. We noted that many persons with contraindications to vaccination with ACAM 2000, for example, those with atopic dermatitis, those with immunocompromising conditions, breastfeeding women, or pregnant women, these individuals may receive vaccination with JYNNEOS. However, such persons may be at increased risk for severe disease if an occupational infection occurs despite vaccination. We've noted that persons with immunocompromising conditions may be less likely to mount an effective response after any vaccination, including after JYNNEOS, even though JYNNEOS can be safely administered to such persons. Persons who are pregnant, immunocompromised, have atopic dermatitis, or breastfeeding may receive JYNNEOS when it is considered imperative to provide protection against orthopoxvirus infections and after careful consideration of the risk-benefit ratio. We've provided an additional reference here for individuals to get more information on the severe complications that we've discussed already. The working group also discussed titer testing, given that as a replication-deficient vaccine, JYNNEOS does not produce a vaccine site lesion or take that has traditionally been used as a marker of successful vaccination. The working group felt that routine titer testing should not be recommended following vaccination with JYNNEOS to confirm successful administration of vaccine, given that high rates of seroconversion were demonstrated in clinical trials. However, titer testing could be considered on a case-by-case basis after consultation with public health authorities for select persons with immunocompromising conditions or those working with more virulent orthopoxviruses such as variola virus or monkeypox virus to confirm that immune response has been achieved. They felt it would be prudent to add the following caveats. A correlate of protection has not been established, and therefore there is no known antibody titer level that will ensure protection, and consequently titer results should be interpreted with caution in such cases to avoid providing a false sense of security. Lastly, the working group felt it would be helpful to provide some guidance for starting work in a laboratory and has put together the following statement. A person can be considered fully immunized 2 weeks following administration of the second dose of JYNNEOS when clinical studies have demonstrated maximal antibody titers. So with that, I will conclude, but I will be happy to take any questions.
Thank you. This presentation is open for any clarifying questions. I don't see any hands raised. So what we can do is go on to Dr. Rao, and after your session, we can take questions on both sessions, or both presentations. So Dr. Rao, go ahead.
Okay, thank you. As a reminder, we have 5 PICO questions. The first and the second are about primary vaccination with JYNNEOS for 2 different at-risk populations. The third and the fourth are about the frequency of booster doses after the primary vaccination series with JYNNEOS in persons with continued occupational risk. And the fifth one is one of the most frequent questions that we have been receiving, and it's about changing from boosters with ACAM 2000 to boosters with JYNNEOS for those who receive the ACAM 2000 primary series. So because there are 5 PICOs, there are 5 evidence to recommendation or ETR frameworks. I'll go over the first one in detail, but for the other 4, I'll move pretty quickly through them because many of the sentiments are the same. So I'll start with the evidence to recommendations or ETR frameworks for the first 2 PICO questions. These are the ones pertaining to the primary vaccination with JYNNEOS. Orthopoxvirus infections cause morbidity and mortality. Several populations are at occupational risk. The first is research laboratory personnel. Research laboratory personnel are defined as those who directly handle cultures or animals contaminated or infected with replication-competent vaccinia virus, recombinant vaccinia viruses derived from replication-competent vaccinia strains, or other orthopoxviruses that infect humans. The second are clinical laboratory personnel performing diagnostic testing for orthopoxviruses. The third are response team members designated by public health authorities to receive the vaccine for preparedness purposes. And the fourth population is select healthcare personnel who administer ACAM 2000 or care for patients infected with replication-competent orthopoxviruses, for example, patients enrolled in clinical trials. ACAM 2000 is currently recommended by the ACIP for persons at occupational risk. If JYNNEOS were to also be recommended, there would be benefits to having more than one effective vaccine available. Additionally, having more than one vaccine provides options. Some people may prefer receiving one of these vaccines over the other. The first PICO question is shown on this slide, and it is, should JYNNEOS be recommended for research laboratory personnel, clinical laboratory personnel performing diagnostic testing for orthopoxviruses, and designated response team members at risk for occupational exposure to orthopoxviruses? I want to draw your attention first to the comparison here. The comparison, since ACAM 2000 is the standard of care for persons at risk for occupational exposure, ACAM 2000 is listed as the comparison. The outcomes listed for this question are the same as for the other 4 PICOs that I'll be presenting. These outcomes listed in the darker font color, so outcomes A, C, and D were deemed critical by the work group to these policy questions, and these are the outcomes that will be evaluated in the evidence to recommendations, the evidence tables. So outcome A, for any of the ETR questions that get at efficacy or benefits, that's the outcome with the of evidence table that we will be looking at. For outcome C and D, those are the ones that assess safety and harms in the questions in the ETR that pertain to that. Oops. Okay, so the first ETR domain is benefits and harms. There are 4 parts to this domain, as I know everybody's familiar with, and so I'll go through each of those in detail in the subsequent slides. So as far as benefits go, the first question is how substantial are the desired anticipated effects? JYNNEOS is not a replicating virus, so there's no potential spread to others. FDA found JYNNEOS to be non-inferior to ACAM 2000 for immunogenicity, and most importantly, the evidence table for outcome A suggests that there is a small benefit of JYNNEOS compared to ACAM 2000 for prevention of disease. And for this reason, the work group concluded that the desirable anticipated effects are small. This is that evidence table. Geometric mean titer, or GMT, and seroconversion rates are two different indirect measures of prevention of disease that we evaluated. In the first row of this table is prevention of disease assessed with GMT, and the red box in that row indicates the mean difference in titer units between those who received JYNNEOS compared to those who received a live replicating vaccinia vaccine, so either ACAM 2000 or Dryvax, which is its precursor, was 1.62 titer units higher. The 95% confidence interval ranged from 1.32 to 1.99 titer units higher. The next question under the benefits and harms domain is how substantial are the undesirable anticipated effects? JYNNEOS is a non-replicating vaccinia virus, so as previously presented, there were fewer contraindications to JYNNEOS compared to ACAM 2000. The RCTs and pooled observational data in the evidence tables indicate fewer adverse events with JYNNEOS, which I will show in a minute. The work group decided that the answer to this question was minimal based on the numbers that I will show you. So in the red boxes is some of the data that was considered for this question. The absolute effect from the RCT data was 3 fewer serious adverse events per 1,000 with JYNNEOS compared to ACAM 2000. And the observational data, which is shown in the second row, as you can see on the far right of the lower box, supports the RCT data. And just to point out, because it's relevant to later aspects of the ETR, there were many more people included in this observational row. So you can see over 5,000 in just the JYNNEOS column of that observational section in comparison to the first row of this table, which shows many fewer persons were included. And the reason for this is, our comparison, as I pointed out earlier, was ACAM 2000. And so the RCTs that involved an arm for JYNNEOS as an intervention and an arm for ACAM 2000 were the ones that were included. Observational studies is the designation given when we had to break that randomization, and where, for example, there was only data for one arm, the JYNNEOS arm, and historical data was used in the ACAM 2000 arm. So even though those studies may have started, many of them, as RCTs, because we only pulled data from one arm, they turned out to be observational data. And as you can see, it is quite a lot of studies in that observational section that show no serious or limited serious adverse events. Similarly, there were fewer myocarditis events associated with JYNNEOS compared to ACAM 2000, and here as well, the observational data supported the same conclusion and offered a lot more data and showed that there are minimal harms from JYNNEOS. So since the benefits were determined to be small and the harms minimal, the desirable effects were determined to outweigh the undesirable effects, and the work group felt that the intervention is favored. The overall certainty in the benefits was moderate based on the evidence table for prevention of disease, and after considering GMT and SCR data together, we have moderate certainty that there is a small increase in disease prevention provided by JYNNEOS compared to ACAM 2000. And again, that's shown here. The certainty level was determined by an assessment of the RCTs for study design, risk of bias, inconsistency, indirectness, and imprecision. GMT is an indirect measure of prevention of disease, and that is what led to level 2 or moderate level certainty for the effect estimate. The work group estimated that there were fewer serious adverse events and myocarditis cases after a JYNNEOS primary series compared to ACAM 2000 vaccination, but there was low certainty in these conclusions, as I'll show you on the next 2 slides. For serious adverse events, RCT data was downgraded due to sample size being small and therefore not meeting the optimal size to assess this rare outcome. Also, the 95% confidence interval from 4 fewer to 27 more included the potential for meaningful harm. The observational data included many more subjects, over 5,000 in the JYNNEOS arm, and showed no harm. So this was reassuring for the work group and is the reason that we presented both the RCT data and the observational data. Similarly, for myopericarditis, there were too few subjects enrolled in the RCTs in the first row here to assess for this rare event. There was therefore very serious concerns for imprecision. And while the observational data included many more subjects, the certainty level for observational studies is low to start at level 3. And it was downgraded here because of serious concerns for risk of bias, because of selection bias, and for indirectness, because this was an indirect comparison of naively pooled single-arm studies compared to a historical control. Moving on to the second domain of the ETR, it is values, and there are 2 questions about values. The first is, does the target population feel that the desirable effects are large relative to the undesirable effects? The work group concluded probably yes. A 2015 CDC study of 275 healthcare personnel in the Democratic Republic of Congo, or DRC, showed that greater than 75% were not interested in ACAM 2000 after they heard what it was, but 98% were interested in JYNNEOS. So among the U.S. target population, although we don't have similar data, we know that there have been many requests for JYNNEOS that we at CDC are receiving, and so that is why probably yes was where the work group settled. For the question, is there important uncertainty about or variability in how much people value the main outcomes, there's no research identified, but stakeholders are expected to value immunity. FDA deemed the JYNNEOS primary vaccination series to be non-inferior to that for ACAM 2000. It's true that it will take longer from the first vaccination before a person given JYNNEOS is considered fully vaccinated, because JYNNEOS involves 2 doses, 28 days apart. The work group concluded, though, that there's probably no important uncertainty or variability. For the acceptability domain, there is ease in finding a provider, and we know that some vaccinees have difficulty finding a provider when it comes to ACAM 2000 because it's administered by a technique that many physicians may be unfamiliar with. It involves a bifurcated needle and multiple punctures. Because JYNNEOS is a non-replicating virus vaccine, there's no risk of transmission to others, particularly to those who are immunocompromised or who have skin conditions like eczema. Adverse events are also expected to be more rare with JYNNEOS compared to ACAM 2000, and for all of these reasons, the work group answered yes, the intervention is acceptable to key stakeholders. So JYNNEOS, like ACAM 2000, would be provided from HHS's Strategic National Stockpile, or SNS, free of cost. And even in cases where employers do not cover the cost of clinic appointments, there may be similar clinic costs associated with JYNNEOS as with ACAM 2000 vaccinations. And that's because in some clinics, patients return for in-person clinic appointments on multiple days after ACAM 2000 vaccination, on days 3, 7, and sometimes several times after that, to perform dressing changes and assess the take site and evaluate for symptoms or complaints of consistent with myocarditis. And so the work group felt that yes, JYNNEOS is a reasonable and efficient allocation of resources. Because there are fewer costs and challenges associated with identifying a provider, equity would be increased, and so increased equity was the answer to this question. And then for the final domain of feasibility, there would likely be the same number of clinic visits as I just mentioned, or possibly even fewer with JYNNEOS. Also, there would be less difficulty getting on a vaccine schedule because more providers would be willing to administer subcutaneous injections. People would not have to necessarily go to military sites to receive it. JYNNEOS, once thawed or refrigerated, is good for 6 months, according to recent approvals made by FDA. And thawed ACAM 2000 is good for longer, for 18 months, but the shipping conditions are the same for both. So the 6-month window allows for ample time for providers to schedule vaccinations. Our CDC Drug Services would be the ones sending it out, and they see no issues with feasibility. And so the intervention is feasible to implement, yes. So just to summarize what the answers were to this particular ETR, and I did go through this one in much more detail, but I'll be going through the other ones much faster because a lot of the answers are the same. You can see that I listed the things that you could consider as positive ones in green, and the possibly negative ones are listed in red. Overall, there's a lot more green, and the balance of consequences listed in the far right corner. The work group felt the desirable consequences probably outweigh undesirable consequences in most settings. And so for this particular PICO question, this is our proposed language for the first recommendation. The ACIP recommends JYNNEOS as an alternative to ACAM 2000 for research laboratory personnel, clinical laboratory personnel performing diagnostic testing for orthopoxviruses, and for designated response team members at risk for occupational exposure to orthopoxviruses. And we have footnotes here to explain several of these categories. So now I'll move on to PICO number 2. It's also about primary vaccination. The policy question is, should JYNNEOS be recommended for healthcare personnel who administer ACAM 2000 or care for patients infected with replication-competent orthopoxviruses? Many of the responses here are the same as what I just presented, and so I'm just listing them here to summarize. It's the very same evidence tables that were used for this PICO, and so the responses are all the very same as what I just presented for ETR number 1. The only differences are the ones that I'm going to highlight here. There are differences in values. So for the question, does the target population feel that the desirable effects are large relative to the undesirable effects? There's no research data to evaluate this, but it's believed that some members of this population will be interested in vaccination, or at least would like the option of being vaccinated, even though it's not indicated for the entire population. And in the past, this is what we have heard when patients were admitted with adverse events from replicating orthopoxviruses. Some healthcare workers were anxious and wished they had been vaccinated, and so allowing it for these persons is consistent with the ACIP recommendations for ACAM 2000 and is something that the work group wanted to do. The ACAM 2000 language for this particular population is that it, in quotes, can be offered. Because of the low risk for such persons who are already wearing personal protective equipment, many may opt to not get vaccinated. So the work group concluded that there is possibly important uncertainty or variability indicating it could be recommended possibly by shared clinical decision making. And the work group responses for all the remaining domains were the same as what I already presented for the first ETR, and so I list them here with the explanation, but I won't go into them in more detail than that. They are all summarized here, and again, the only differences are highlighted in yellow from the only differences from the first ETR, but it is those differences that led the work group to think that this should probably be recommended by shared clinical decision making. And the balance of consequences is listed in the far right. The desirable consequences probably outweigh the undesirable consequences in most settings. And the phrasing of that, the proposed recommendation for the votes later today is listed here. The ACIP recommends JYNNEOS based on shared clinical decision making as an alternative to ACAM 2000 for healthcare personnel who administer ACAM 2000 or care for patients infected with replication-competent orthopoxviruses. And again, there's a footnote here to explain what we mean by this. Moving on, ETRs 3 and 4 are about the frequency of JYNNEOS booster doses after the JYNNEOS primary series. The problem here is that virulent orthopoxviruses, for example, variola virus and monkeypox virus, an increasing number of laboratories are working with monkeypox viruses, so example, primate laboratories. And work with these typically requires personal protective equipment and other safeguards, but ensuring long-term immunogenicity through a booster provides an additional level of protection if unintentional breaches occur. Less virulent orthopox viruses, like for example, vaccinia virus, cowpox virus, and Alaska pox virus, The morbidity may be prevented. Example, a mild case of vaccinia infection occurring in a laboratory in the United States who had not received a booster greater than 10 years after his primary ACAM 2000 vaccination occurred in the past, and these could potentially be prevented with the recommended booster. The stakes are higher to individuals and to public health if virulent orthopoxvirus infections are acquired. As you might imagine, monkeypox or smallpox in a laboratorian would be a very large problem for public health, whereas an individual getting infected with vaccinia virus is not is of concern to that individual, but is not a concern on a population level. And so for this reason, boosters historically have been given more frequently for those working with virulent orthopoxviruses compared to those working with the less virulent orthopoxviruses. You'll remember this slide from Dr. Peterson's presentation, and also it was presented during the September 29th meeting. The last two rows is what I wanted to draw your attention to. The frequency of boosters for those working with the more virulent orthopoxviruses is every 3 years for ACAM 2000, but for JYNNEOS, the work group is proposing 2 years, as I will show in the next few slides. And then for frequency of boosters, the recommendation for ACAM 2000 was at least every 10 years, and the work group is proposing the same for JYNNEOS. So the third policy question states, should persons who are at continued risk for occupational exposure to more virulent orthopoxviruses, such as variola virus or monkeypox virus, receive a booster dose of JYNNEOS every 2 years after the primary JYNNEOS series? And the comparison here is no vaccine booster after the JYNNEOS primary series, similar to what I've already presented. The outcome A here, prevention of disease, is what is the information from that evidence table is what informs the answers to efficacy and benefits. And the last two here, outcomes C and D, are the ones that inform the ETRs for the grade tables for those are what informs safety and harm-related questions in the ETR. The proposed policy questions for PICO number 4 is similar, but let me read it here. It should persons who are at continued risk for occupational exposure to less virulent replication-competent orthopoxviruses like vaccinia virus or cowpox virus receive a booster dose of JYNNEOS at least every 10 years after the primary JYNNEOS series. So I'll just summarize the benefits and the harms. These are the same for both PICOs 3 and 4. How substantial the desirable anticipated effects? The work group felt small. The evidence tables show a small increase in disease prevention after JYNNEOS booster to the JYNNEOS primary series. Boosters may provide reassurances of continued protection from inadvertent exposures, though. Harms, how substantial are the undesirable anticipated effects? There are no minimal is what the work group felt. There are no serious adverse events or myopericarditis. Reports observed among those who received JYNNEOS booster dose 2 years after the primary series. And so because of the benefits being small, the harms being minimal, the benefits to harm ratio favors the intervention. The overall certainty, though, of the evidence for the critical outcomes is very low for both, and that's really just because of the limited data that's available about booster doses, as shown here. The red box is around the data that informed the question about benefits, and in the yellow box is the certainty of that conclusion. What it really means is that we estimate that there is a small increase in disease prevention after JYNNEOS, after a JYNNEOS booster after the JYNNEOS primary series versus just the JYNNEOS primary series with no booster. However, we have very low certainty in that estimate. And I want to draw your attention to the highlighted text here on this slide. The reason that we have for PICO number 3 that the answer was serious, and for PICO number 4 the answer was very serious, is because there is data for the 2-year time point for a booster dose, but there is no data beyond the 2-year time point. And so it is indirect data informing the 10-year booster recommendation. It was somewhat arbitrarily chosen by the work group, but The work group felt strongly that there had to be a recommendation about when people working with the less virulent pathogens orthopoxviruses should get a booster dose, or otherwise it would be forgotten. 10 years was chosen because 2 years was clearly too often, and 10 years was the same as what is recommended for ACAM 2000, and that's why it was recommended. But you can see here that despite the answer being different for PICO 3 and PICO 4 for this indirectness section here, it really didn't impact the certainty level. It was very low for both. And now for harms, the evidence tables for both serious adverse events and myopericarditis were considered. This slide shows the evidence table for serious adverse events. There were no cases of serious adverse events after the JYNNEOS booster, as you can see here in the red box. The effect estimate for the randomized control trial and observational data were not estimable because there were no recorded events of vaccine-related serious adverse events after the booster. You can see the denominators, though, are too small to have identified a serious adverse event for what we know is a rare occurrence, even for ACAM 2000. And so we have very low certainty in that estimate of the serious adverse events for that reason, of the serious adverse events being extremely rare. For myopericarditis, there were also no cases, but the number of enrolled subjects was extremely low for both arms. With the available data, we cannot estimate the effect of JYNNEOS plus a booster compared to just the JYNNEOS primary series, and so we have very low certainty in this conclusion. This table summarizes the remainder of the ETR domains for PICOs 3 and 4. All of the workgroup responses to these questions were positive, as you can see in green. I'll go over these, and again, these are the same for PICOs 3 and 4. So value, does the target population feel desirable effects are large? Probably yes, because the booster may be desirable to those who want to ensure long-term immunogenicity. Is there important uncertainty about or variability in values? Probably not. Stakeholders are expected to value persistent immunity. Acceptability to the stakeholders, yes. It's easy to find caregivers to administer the vaccine. Is it a reasonable and efficient allocation of resources? Yes, for the third PICO, which is about boosters in people who deal with the more virulent orthopoxviruses, and the work group felt probably yes for those who deal with the less virulent orthopoxviruses. And the explanation there is that for persons working with less virulent orthopoxviruses, there could be costs associated with clinic visits, but we still think it would likely still be acceptable, and that is why the work group said probably yes. Impact on health equity, probably no impact. For many, employers absorb the costs. And for feasibility to implementation, probably yes. They need to get a booster dose, but many clinicians can provide that subcutaneous injection. And so the balance of consequences here in the far right corner, as you can see, is that the desirable consequences probably outweigh undesirable consequences in most settings. And I will show the proposed language for each of these two recommendations. This slide shows the proposed language for recommendation 3. The ACIP recommends persons who are at continued risk for occupational exposure to more virulent orthopoxviruses like variola virus or monkeypox virus receive booster doses of JYNNEOS every 2 years after the primary JYNNEOS series. And the asterisk here is for the phrase continued risk. Continued risk refers to persistent risk due to occupational work performed. Designated public health and healthcare worker response teams are vaccinated for smallpox and monkeypox events if they are to occur and are approved by public health authorities for that reason, for preparedness purposes. They're not considered at continued risk because they're vaccinated for the purposes of preparedness. And then the phrasing for the fourth proposed recommendation, the ACIP recommends persons who are at continued risk for occupational exposure to replication-competent orthopoxviruses like vaccinia or cowpox receive booster doses of JYNNEOS after the primary JYNNEOS series. I'm sorry, this should say at least every 10 years. So we'll insert that for the vote. It should say at least every 10 years. They should receive booster doses of JYNNEOS after the primary JYNNEOS series. And the asterisk here, continued risk refers to persistent risk due to occupational work performed. Now to the last ETR, which I mentioned was one of the most frequently asked questions that we are being asked. So health authorities and the JYNNEOS sponsor are routinely being asked when this vaccine will be available. Some laboratory directors have indicated that many of those who receive ACAM 2000 boosters would like to change to JYNNEOS if the ACIP recommendations explicitly allow for this. And this is because of the ease of identifying a clinician who can administer it, no risk for infection spread to others, no dressings to manage, and fewer relative contraindications. The unpublished data from the Democratic Republic of Congo indicates that JYNNEOS is also preferred to ACAM 2000. So this fifth PICO is, should persons who are at continued risk for occupational exposure to orthopoxviruses and who received an ACAM 2000 primary vaccination receive a booster dose of JYNNEOS as an option to a booster dose of ACAM 2000? And here the comparison, so the intervention is a booster with JYNNEOS and the comparison is a booster with ACAM 2000. The outcomes are the same as what I previously described. So for this here, the benefits, how substantial are the desired anticipated effects? The work group said don't know, and that is because there's only observational data, which I'll show in the next slide, for this outcome. There was no available comparison data for that, so it's unknown from the evidence table how substantial the desirable anticipated effects would be if a JYNNEOS booster is given to those individuals who were previously getting ACAM 2000 boosters instead of the ACAM 2000 booster. Now for harms, how substantial are the undesirable anticipated effects? They're minimal. No serious adverse events or myopericarditis cases were identified. The benefit to harm ratio, because the benefits are unknown, is unclear. We don't know if there are benefits to administering JYNNEOS boosters compared to ACAM 2000 boosters. And the overall certainty of the evidence for the critical outcomes are very low for both effectiveness and for safety. For outcome A, which is the one that informs the effectiveness part here, the RCTs show serious concerns about risk of bias, indirectness, and imprecision. And outcome C and D, which inform the RCTs from those which inform the safety part here, there are serious or very serious concerns about risk of bias and very serious concerns about imprecision that contributed to this very low rating. And that is demonstrated here in this table. The information from outcome A prevention is in these red boxes here. And again, serious adverse events, there's two slides for harms. This is for serious adverse events, and the next one is for myopericarditis. Taking randomized control trial data and observational data, we can say that we estimate that there were fewer serious adverse events after a JYNNEOS booster compared to an ACAM 2000 booster, and people previously vaccinated with ACAM 2000, but we have low certainty in this estimate. And then for myopericarditis, we estimate that there were no myopericarditis events regardless of whether a JYNNEOS booster or ACAM 2000 booster was given to persons previously vaccinated with ACAM 2000. However, we have very low certainty in this estimate, partly because of the very small number of subjects included in the analysis. This is not something that was evaluated. So then the summary of the remaining domains are shown on this slide, and you can see in green that they're all positive. The values, the target populations have made multiple requests for this vaccine. Unpublished data from the DRC indicates strong interest in JYNNEOS. Regarding is there important uncertainty about or variability in values? Probably not. Anecdotally, we know that some laboratory directors anticipate many of their staff to change to JYNNEOS boosters if the ACIP explicitly indicates it's acceptable. And that's why we included this PICO. Acceptable to stakeholders, yes. Ease of finding a provider. There's no risk of transmission to others. There's no work absences due to travel to get the vaccine, and then fewer contraindications with JYNNEOS compared to ACAM 2000. Reasonable and efficient allocation of resources, yes. It would be the same as for ACAM 2000 booster. It's provided free of cost by the U.S. government, by the SNS. Impact on health equity, it's probably increased because there's no cost with travel and all that you to find a provider. There's stories that
apologies, somebody must need to go on mute.
Okay, and then feasibility, yes, it's feasible for CDC's drug services to ship and for product to be used within the 6-month time interval after that. And so for a balance of consequences, the desirable consequences probably outweigh the undesirable consequences in most settings. And the phrasing of the recommendation is shown here on this slide. The ACIP recommends persons who are at continued risk for occupational exposure to orthopoxviruses and who received an ACAM 2000 primary vaccination receive a booster dose of JYNNEOS as an option to a booster dose of ACAM 2000. So you can see that none of these recommendations are preferential recommendations for JYNNEOS and are intended to be an option. Proposed clinical guidance, I just wanted to mention that the work group feels that if recipients change from ACAM 2000 to JYNNEOS, then they should receive subsequent boosters according to the JYNNEOS vaccination booster schedule. So that would be every 2 years instead of the every 3 years, which is the ACAM 2000 recommendation. And the reason, again, that we chose that is because there is actual data about the 2 years, but there's no data beyond that, so we aren't sure whether or not boosting is possible. We assume it is, but because there's only data up into the 2-year time point, we wanted to be conservative. And they should adhere to the booster schedule for JYNNEOS from there on out. And if they do switch to JYNNEOS, the expectation is that they would stick with JYNNEOS. But if there are changes in people from JYNNEOS to ACAM 2000, we believe that's going to be occurring much less frequently, and that those could be handled on a case-by-case basis. And so with that, I have finished my presentation. I want to thank all of the people listed on this slide. It's been a large effort, and so I just want to thank all the people listed here. Thank you.
Great, thank you very much. And now this entire session is open for questions. And particularly if you have any questions about the votes themselves or the wording of the votes, that would be incredibly helpful. While we're waiting for hands to be raised, I actually have one question, perhaps for Dr. Peterson. It relates to something Dr. Sanchez brought up earlier in a COVID vaccine session, which is around this question about myopericarditis, and it looks like the risk is lower. What is the timing of myopericarditis in relation to the vaccine? And does that, would the work group make any suggestions about concomitant vaccine use, in particular with COVID-19 vaccines?
Yeah, thank you for those questions. So in terms of the timing of myopericarditis, I can get back to you the exact days, but it is within that generally 10-day time frame, so similar to what you see with other vaccines. And with regards to concomitant administration of other vaccines, I think that is a concern. We know that our DoD colleagues have raised that as a potential issue, given that in their population, they do receive multiple vaccines at the same time, including smallpox vaccine. And so they are actually planning a separate study to evaluate that, so that they can get a better handle of the risk of concomitant administration of this specific vaccine, JYNNEOS, with the other vaccines that they administer.
Thank you. Dr. Daly?
Yeah, thanks so much. And thanks for those excellent presentations. I hope I'm not sort of opening a can of worms here, but Dr. Rao, could you just provide kind of a big picture overview of considerations around a preferential recommendation versus a neutral recommendation between JYNNEOS and ACAM 2000?
Yeah, I'll do my best. So there's no preferential recommendation, which means that people can choose either one. And even though our PICOs were set up where several of them, the intervention was JYNNEOS and the comparison was ACAM 2000, the actual recommendations themselves are not saying that you should stop taking ACAM 2000 and only get JYNNEOS or vice versa. They are intended to allow people to have that option of choosing one or the other. The reason we had to set up the PICO questions the way that we did was because ACAM 2000 is currently the standard of care for people at occupational risk for orthopoxviruses, and that's the reason that the first two questions had to have those as the comparator. Did I answer the question? We hopefully.
Yeah, I mean, I guess the corollary is there's insufficient evidence to make a preferential recommendation.
Yes, that's correct.
Okay, thank you.
Thank you. Dr. Talbot.
Yes, I just had one question. Since this is a newer vaccine and it uses a non-replicating virus instead of the traditional replicating, I'm assuming that the duration of protection or antibody may be shorter. What are the plans to follow these folks who are on a 10-year cycle, make sure that they are given adequate protection for 10 years?
Hi, so this is Brett Peterson. So yes, you're correct. In the clinical trials that have been performed, we have seen that the antibody titers do drop off with time. So the persistence of antibodies it is shorter with JYNNEOS compared to ACAM 2000. However, we have seen that specifically with the data at the 2-year time point, that immune response, that memory immune response does persist, and that those individuals do boost with a robust antibody titer following booster dose. However, with regards to your question about how that will be followed, there are some discussions of performing additional vaccine studies to evaluate how far this immune memory response persists. In particular, in our DRC vaccine study, we do plan to do a follow-on booster study at time points beyond 5 years to evaluate whether individuals who have received primary vaccination with JYNNEOS do retain that memory immune response at those later time points. And with regards to whether this vaccine is recommended and how we would follow that in the real world, CDC does do consultations for exposures that occur in the laboratory as well as infections, and we keep track of those. So we would perform our routine surveillance to evaluate if there's any real world effectiveness data that would be relevant in this population receiving JYNNEOS. So hopefully that largely answers your question.
Okay, thank you. Dr. Sanchez?
Thank you, Grace. No, and thank you, Agam. So a couple of what was mentioned, I think that we really, in response to Dr. Daly, we really did want to stay away from a preferential recommendation. The limited experience, but also we, from past experience, we really did not want to go that route, but offer it as a very worthwhile and important alternative. I will say that it is very sought after among the laboratory personnel and the heads of the laboratory personnel who deal with these viruses. And so it's certainly something that's very much, I think, ultimately will become preferential in practice, although we did not want to make that preferential recommendation. In terms of the pericarditis that Grace, you brought up, my understanding is actually that DOD individuals do separate the two out and don't give it at the same time. And we could get more information from them, but I think that they were initially vaccinating with the COVID vaccine and then waiting a period of time to give the ACAM 2000. So I do think that there is some wording there that will need to be in the in the clarifying statements on the use of the vaccine. Thank you.
Yeah, thanks, Dr. Sanchez. We will ensure that it's part of our guidance then for this product. And we've let the COVID-19 clinical guidance folks know about this issue as well.
Yes, thank you. I guess my one, sorry, I'm jumping in, Ms. McNally, but just my one concern is that like this vaccine is only given to a very small population. I think adding it to the COVID-19 clinical guidance, which is so complicated already, would just confuse people. And so my thinking is that we target it to this group of individuals who are receiving this vaccine to be mindful that other vaccines, they might want to consider separation until additional information is found. I think that clinical considerations document is like 89 pages. Okay.
I agree.
Okay, thank you. Ms. McNally.
Thank you. I'm not immediately recalling what we've discussed regarding patient counseling information. So specifically, what the recipients get with potential benefits and risks of vaccination with JYNNEOS, and also informing them of the importance of completing the 2-dose series. Thank you.
Thank you. This is Brett Peterson. So I think it is a routine practice that individuals receiving ACAM 2000 are counseled about risks and benefits, and so that is done before the occupational work is done. With regards to your second question about the importance of the 2-dose regimen, I think it would be reasonable to include information to ensure that individuals are receiving both of those doses so that they do achieve that maximal immune response and the equivalent antibody titers to what was seen with the previous vaccine, ACAM 2000. Thank you for that comment.
Thank you. And I just want to confirm, Dr. Laird, did you have a question or a comment?
I was just wondering, it's not really a relevant question. I'm just wondering, are there any benefits to ACAM 2000 over JYNNEOS that I'm not seeing? But it's not really relevant for today.
Yeah, so there are several possible benefits. One is that, as we've discussed, ACAM 2000 does produce a vaccine site lesion or take, and that has been used as evidence that there's successful vaccination. That's a visual marker that can be easily evaluated, and there's no similar visual marker, there's no vaccine site lesion that occurs with JYNNEOS. The only other potential benefit I might mention is that ACAM 2000 is the only smallpox vaccine that is most closely related to the vaccines that were actually used to eradicate smallpox. So in terms of actual real-world effectiveness in preventing disease, you could consider the data to be stronger for ACAM 2000 for that specific scenario. Those are the only comments that come to mind. Dr. Rao is also mentioning that given the current proposed recommendations, there is also the difference in the frequency of boosters, where boosters with JYNNEOS are recommended every 2 years for those working with the more virulent orthopoxviruses, compared to every 3 years, so a little bit longer frequency for ACAM 2000.
Thank you. I don't see any new hands raised, unless Ms. McNally, you had an additional question.
No, apologies. I'll take my hand down.
Thank you so much. So with that, I think what I'd like to suggest, since there are no other hands raised, is that we move to the proposed recommendation language. So if you're able to put up, we have 5.
Slide 27.
Thank you.
Sorry, each of them separately.
Yes, since there are 5 separate votes, correct.
Slide 27.
So would you like to just read through the vote language?
Yeah, sure. The ACIP recommends JYNNEOS as an alternative to ACAM 2000 for research laboratory personnel, clinical laboratory personnel performing diagnostic testing for orthopoxviruses, and for designated response team members at risk for occupational exposure to orthopoxviruses.
Thank you. So I'm going to ask if any members would like to make a motion for proposed recommendation 1. Dr. Sanchez?
Motion to approve the language and the recommendation.
Thank you. And may I have a second? Dr. Paling? You may be double muted again.
You're correct. I'll second that motion.
Thank you, Dr. Paling. It's been moved and seconded that we vote on proposed recommendation 1 as listed on the slide here. So we will move on to proposed recommendation number 2.
So that would be slide 34. And it says the ACIP recommends JYNNEOS based on shared clinical decision-making as an alternative to ACAM 2000 for healthcare personnel who administer ACAM 2000 or care for patients infected with replication-competent orthopoxviruses.
Thank you. Ms. Bata?
Yes, I propose that we accept the recommendation as worded.
Thank you. We have a motion on the table, and I need a second. Dr. Alt?
We'll second the motion.
Thank you, Dr. Alt. So it's been moved and seconded that proposed recommendation number 2 go to a full vote, and we will then move on to proposed recommendation number 3.
That's slide 45. So this says the ACIP recommends persons who are at continued risk for occupational exposure to more virulent orthopoxviruses like variola virus or monkeypox virus receive booster doses of JYNNEOS every 2 years after the primary JYNNEOS series.
Thank you. And I get a motion. Dr. Daly?
I motion that we approve this language.
Thank you, Dr. Daly. And a second, Dr. Long?
I move to second this recommendation as stated.
Thank you, Dr. Long. It's been moved and seconded that we accept the vote language for proposed recommendation number 3. We will move on to proposed recommendation number 4.
That is slide 46. And this says the ACIP, and this is the one where I have inadvertently left some words out. So this is the ACIP recommends persons who are at continued risk for occupational exposure to replication-competent orthopoxviruses like vaccinia or cowpox, and then it should say receive booster doses of JYNNEOS at least every 10 years after the primary JYNNEOS series.
Thank you. Dr. Cotton?
I would like to propose that we vote on this as worded with that addition of the 10 years, less than 10 years.
I think greater than or equal to 10 years, just to confirm.
At least every 10 years.
At least every 10 years, okay. At least, oh, I see, at least
At least 10 years, at least every 10 years after the primary JYNNEOS series.
Okay, thank you. With that, I'm going to call it wordsmithing as opposed to amendment. And can I get a second, Dr. Sanchez?
I second that.
Thank you. So it's been moved and seconded that the ACIP vote on the proposed recommendation number 4 is listed. And proposed recommendation number 5.
That's slide 55. The ACIP recommends persons who are at continued risk for occupational exposure to orthopoxviruses and who received an ACAM 2000 primary vaccination receive a booster dose of JYNNEOS as an option to a booster dose of ACAM 2000.
And Dr. Sanchez?
I would like to recommend it as this recommend, make the recommendations to approve this as worded.
Thank you. So there's a motion on the table to accept the vote language as is. Dr. Chen?
I will second that motion.
Thank you. So it's been moved and seconded that we accept the vote language for proposed recommendation number 5. And Dr. Long would like to make a comment.
I just wonder why we're changing words in this 5th one as an option to a booster dose. You've used alternative early on where I don't even remember that we offer other vaccines that also work as alternatives. We just recommend them. But since you've used that word alternative, why are you changing to a word as option? I would think keep the language the same unless you're meaning something different.
Yeah.
So I wonder if you would consider changing this as an alternative to a booster dose. And then you'd have to, for whichever way it goes, I guess it could go either way. You'd have to say how many years after the primary.
Thanks, Dr. Long, for that comment. We were just internally here thinking that maybe this could be revised such that everything after the word JYNNEOS is dropped. So I'll read it again. If it were revised, it would say the ACIP recommends persons who are at continued risk for occupational exposure to orthopoxviruses and who received an ACAM 2000 primary vaccination receive a booster dose of JYNNEOS. May receive a booster dose of JYNNEOS.
Sounds good.
Dr. Sanchez, any concerns?
No. I was going to add the may.
Thank you. So I'm taking this as a minor revision of wording and not changing the intent of the recommendation. So the motion and the second will stand as is. And are there any other concerns or questions that people have on any of the 5 votes that are upcoming? Okay. I don't see any hands raised. So with that, why don't we take, would we like to go ahead to Ebola, or would we like to take a 5-minute break? I'm going to suggest we take a 5-minute break just so we can gather ourselves. So let's just say 9 minutes after the hour, we'll meet at 3:09. Thank you, everyone.